So this is an overview of cardiogenic pulmonary edema. So I wanted to quickly run through the anatomy and pertinent anatomy and physiology of the heart before we carry on. So we have the right side of the heart, the left side of the heart. The right side of the heart is fed by veins. So we have two massive veins that feed the right atrium. So we have the superior vena cava and the inferior vena cava. These both flow into the right atrium. The right atrium fills up, flows into the right ventricle. It flows through a valve called the tricuspid valve. When the right ventricle becomes filled and it's time for contraction or systole, the right ventricle will contract and the blood will go through the pulmonary valve, which is a semilunar valve, and that will travel through the pulmonary vein to the right and left lung. The right and left lung will have diffusion of gases into the blood, and they will travel back to the left atrium as the pulmonary veins. So it goes into the pulmonary arteries to the left and right lungs, back as the pulmonary veins into the left atrium. Left atrium will fill up, and then blood will flow through the left atrium into the left ventricle through the mitral valve. As the left ventricle contracts, it will flow through the aortic valve into the aorta and to the rest of our body, and then the cycle continues when it goes into the left atrium. So major factors to remember when we look at cardiogenic pulmonary edema is the left atrium, left ventricle, aortic, mitral valves, and the pulmonary veins. So we'll just touch on the anatomy of the heart. Now from the right ventricle into the pulmonary artery through the pulmonary valve, we're going to the lungs. So the lungs are made up of the left and the right lung. Right lung has 3 lobes, left lung has 2 lobes. We then go from the pulmonary artery into a pulmonary capillary, into a pulmonary vein, and then that will travel to the left atrium as oxygenated blood. This is the alveoli. So this isn't anatomically correct, but it's a good description. So alveoli are air sacs that are a functional part of the lungs where gas exchange occurs. So alveoli would be bunches of grapes, which will feed into a tube. This tube would be a bronchiole. Bronchiole would go to the trachea, trachea to the mouth. That's sort of what we're looking at. Each alveoli will have a pulmonary capillary. So this is what's described here, with an endothelium and a bunch of proteins between the blood and the alveoli. So normally what happens here is that we have a pressure difference. So to stop the blood from just diffusing across into the alveoli, we have a pressure. So we have proteins around the alveoli, and we have pressure within the pulmonary capillary. So now we're going to look at hydrostatic pressure. Well, hydrostatic pressure is the blood exerts a pressure on the walls of the endothelium. So the walls of the capillary as pressure from the blood. So this is an equal, it goes in every direction. So that's our hydrostatic pressure. The proteins exert a different pressure. They exert oncotic pressure, which opposes the pressure within the capillaries. So in a person, to stop blood traveling from the capillary into the alveoli, the oncotic pressure needs to be higher than the hydrostatic pressure. So we think of a door analogy. So if we had an adult on this side, an adult on this side, and a door between alveoli and capillary is in between. So the two adults are both the same size, they both oppose each other, and therefore the door will stay closed, therefore no blood will travel through into there. And the only thing that will occur is that oxygen and carbon dioxide will diffuse across. So this is where we look at hydrostatic pressure and oncotic pressure. So hydrostatic pressure being one of the adults and oncotic pressure being the other adult. So think of it as a door theory. blood stays in the capillary and gas diffuses across. So we just touched on oncotic pressure versus hydrostatic pressure with the analogy of a door with two adults on each side. Now let's go back. So the blood has been oxygenated from the alveoli. It's gone into the pulmonary vein. It now travels through from the right lung, the left lung, through the pulmonary veins into the left atrium. So the left atrium will fill up, and then the blood will travel into the left ventricle. Left ventricle will contract, and the blood will travel through the aortic valve into the aorta and to the rest of our body. So the left atrium has the mitral valve, and the aortic valve is here. Some quite significant terms we need to remember here is left ventricular ejection fraction. So this is essentially how much blood this left ventricle will pump out each beat. The volume of blood that enters the left ventricle that makes it pass into the aorta is known as our ejection fraction. Our left ventricular filling pressure, well, is how much pressure is in this left ventricle when it fills. Afterload, so if we think of afterload being the resistance, so afterload is just another term for resistance pretty much, and we think of a tap. So you have a tap and then you have a hose. So if you have a small hose and a big hose, so if we increase the afterload, this is essentially putting the small hose on that tap. So if we, in both scenarios, if we turn the tap once, so we have the equal amount of water coming through, so the ejection fraction, so the amount of blood exiting, is at one turn of the tap, so the left ventricle is the tap in this case, and we put a small hose on. So that would represent vasoconstriction. So if the aorta was smaller and the rest of the arterial system was smaller, a small hose would have an increased resistance, so that tap would have to work harder to push the blood through a smaller diameter. If we put vasodilators, so if we reduce the afterload, so say we have this patient GTN, the aorta and the rest of the arteries would become bigger. So this would be, in fact, like putting a large diameter hose onto this tap. So the tap would have to work less hard to pump the same amount of blood through. So afterload is just a resistance. So think of it as a tap with a hose. So if you increase afterload, you put a smaller hose on. If you decrease the afterload, you put a bigger hose on. So now we look at left heart failure or heart failure. So we just touched on the pertinent anatomy, how the gas exchange, we looked at the hydrostatic pressures, we looked at how the left atrium, the left ventricle get their blood, and we looked at afterload and ejection fraction. So now we're looking at heart failure. So heart failure is more of a state rather than a disease or a condition. So heart failure is more of a general term to describe the function or structure of a heart. So we define heart failure as a syndrome of signs and symptoms because of abnormal cardiac structure or function, and/or function. So therefore, to say that someone has acute heart failure would mean that there's acute onset of worsening signs and symptoms, so their state has deteriorated because of some precipitating cause. So a precipitating cause is something that has triggered this patient already has heart failure, but something has happened in this patient's life that has made their heart worse. So we'll touch on this later. So I want to touch on how does this part become abnormally structured or has an abnormal function. How does this patient normal heart go to a state of heart failure? So we're looking at the left side of the heart. So we have the right lung over here. I'm not sure if it crops properly, with the pulmonary veins into the left atrium from the left lung as well. Left atrium, mitral valve, left ventricle, aortic valve, aorta. So what would cause someone's heart to become abnormal structure or function? So we have long-term hypertension. So if someone had long-term hypertension, this is the long-term afterload. So if you think that their aorta, the rest of the arteries are very small, so that's that small hose that we've put on that tap. Over time, this left ventricle will become fatigued it would become weak. The muscle essentially would increase in size, but the amount of space in here would decrease. There'd have to be a give. More muscle, less space. So therefore, there'd be less blood being able to be pumped out from his left ventricle. So long-term hypertension will just fatigue this left ventricle over time. So that's one. ACS. So ACS has been a multitude of conditions where essentially atherosclerosis or a decreased amount of blood supply to the myocardium has occurred. So if you think that long-term ACS, so long-term decreased blood supply, decreased oxygen supply to this patient, this myocardium is going to become weak. Its muscles on a decrease in size, it won't be able to pump blood out as much. So therefore its function would be dramatically decreased because it won't be able to pump out as much. Heart attack. So if someone's had a massive anterior lateral heart attack, anterior septal, and anterior myocardial infarction, so where the left ventricle is taking the brunt of that, so whatever blood vessel was supplying the left ventricle, usually the left anterior descending artery, that has become occluded. There's no blood supply to this side of the heart, so this left ventricle becomes necrotic. Necrotic tissue dies. Unfortunately, we can't regenerate cardiac tissue. So all the tissue that regenerates here is scar tissue, and scar tissue is not functional at all. So therefore, heart attacks will decrease the function and also affects the structure. Valve problems. So we have the mitral valve, we have the aortic valve. So we're talking about valve problems as stenosis or regurgitation. Regurgitation would mean that, say, the left atrium was to regurgitate. So mitral valve will regurgitate. So when the left ventricle contracts, this forces the mitral valve to close, so therefore no blood will go through there. However, when there's regurgitation, as blood flow comes through the left atrium, increases the amount of blood in the left ventricle, dilates it, and causes strain on the left ventricle. Now we look at the aortic valve. Stenosis. Stenosis is just a stiffening of the valve. So if you think that this opening becomes stiff and the left ventricle has to work harder to pump the blood through, that's when we get our weaker heart and less functional. And regurgitation would be blood coming back and we'd have a weaker heart. Myocarditis is just the inflammation, infection of that heart. So what is the overall problem here? So we have a weaker left ventricle, it decreases the amount of blood it can pump out, decreased cardiac output, and a poor performance. So its function and structure are decreased. So therefore, we have a weak left ventricle. That's what's heart failure. So this patient that we have heart failure in, so they have chronic heart failure, so the left ventricle is not functioning properly. So then for when someone has APO, they need a trigger. So that we need that precipitating cause to have this patient go from heart failure to acute pulmonary edema. So what causes acute pulmonary edema in these patients? So say someone had an infection, so their metabolism would increase, their heart rate would increase. There'd be a bunch of chemicals in their blood that all irritates or puts increased demand on the heart. So this left ventricle cannot keep up as much. It's weak, as we talked about before. Therefore, its performance would dramatically decrease in that short period of time, and the patient would deteriorate fast. Volume overload. So say this patient had too much salt, they had too much fluid retention, they were on dialysis, they missed a few appointments. There's an increased amount of blood in their system. That same amount of blood is going into this left atrium, into the left ventricle, but the left ventricle can't pump it out as much. So therefore, we have a poorer cardiac output, and we have strain, and the left ventricle becomes structurally poor. A heart attack. So this patient had a massive heart attack, and commonly this is what we will see, is that this patient will have a heart attack, the left ventricle would reduce its function even further, therefore it won't be able to pump as much blood out. ACS, again, same situation, decreased supply of oxygen. Left ventricle needs that oxygen, needs that nutrients. It's not getting them, so therefore its performance is problematic. Sympathetic nervous system trigger. So say someone had a traumatic brain injury, sepsis, flight or fight response, where someone needs that compensatory mechanism. That's all well and good in a healthy heart, but this heart cannot keep up with a sympathetic nervous system trigger. Tachycardia would be really, really bad for this patient. And therefore, that's where we look at arrhythmias. So imagine having AF in this patient. 40% of these patients may have AF. That's caused this exacerbation. So 40% have a new onset AF. And then increased blood pressure, so that might be poor compliance with blood pressure medication. So they're beta blockers, so calcium channel blockers, they're ACE inhibitors, poor compliance, so therefore their blood pressure increases, puts more strain on this. So when we talk about blood pressure, increased afterload, so more strain. What's the problem here? So left atrium, so I'm indicated the blood supply with these arrows. So it's a normal blood supply, so same amount of blood, but the left ventricle can't pump out as much blood. So it has a little arrow. So it can't pump out as much, but it's still receiving the same amount of blood. And this causes a problem. Where does this extra blood go? The left ventricle can't pump that extra blood out. It hasn't got the function, hasn't got the strength anymore. It's a little old lady. It can't keep up. So where does this blood go? And that's what the next step is. So where does that blood go? The answer is the lungs. So unfortunately, the left ventricle can't pump it out, so it can't go forward. It needs to go, it can only go back. So it goes through that mitral valve into the pulmonary veins, and then back to the right lung and the left lung. So back at the lung, so we have this alveoli. So this is normal. If we look at this half of it, it's still doing the blood from the right ventricle, still doing that normal amount of blood from the right ventricle. We get oxygen diffusion. However, this blood from the backflow blood from the left atrium to the left ventricle couldn't pump it out as much. Remember that little arrow from before? Can't go forward, can only go back. So this like sort of a tidal wave of blood comes through. And we have a backflow. So we have more blood volume in this area, and blood volume means more pressure. So if in that hose example, say we had the normal size hose, this hose size stays the same, but the amount of water in that hose increases. So we turn that tap a few more times. So instead of being in one rotation, we're cranked it up to 5 rotations. So that's what and then you can imagine if you looked at a hose and you did that, the pressure would increase. It would come out faster. So what does this backflow? Backflow increases blood in the capillaries and increases the pressure. So think of that hose. You remember that door scenario I talked about before when we had the 2 equal adults on each side, and the door would be the gateway between the blood and the alveoli, and the 2 adults were able to resist each other and counter. This scenario means that this backflow, this is now the Hulk on one side, and we have an adult on the other side. Who do you think's going to win? Well, the Hulk's going to win, and Hulk in this scenario is this side of the bloodstream. That's the Hulk, and this is the little man. The door's going to open, isn't it? The Hulk's going to smash that doorway open, and blood's going to go in, isn't it? So we have hydrostatic pressure. The Hulk is greater than oncotic pressure, which is the adult. What does this represent? So the door opens. So the door opens and we get blood going in. Blood, fluid, it's all the same thing really. Therefore we get this filling, the alveoli become flooded. So I've just represented it. It probably doesn't look like this, but this is probably a good analogy. Just like a fluid, like you're filling up a bowl. This happens everywhere in the lungs. So every lobe, this is diffuse. And this is acute pulmonary edema. How does our patient look? So we've now described the anatomy. We described heart failure. We described what causes heart failure to go into a state of acute pulmonary edema, where that left ventricle reduces its function. We looked at how the alveoli become flooded. Now let's look at what's your patient going to look like. This is what the alveoli look like. So they're all these little sacs that group, and you have an alveoli sac, they become bronchioles, and then further on. It happens everywhere. So look at all these little alveoli flooded. This is everywhere. And the first sign you're going to see is dyspnea, so difficulty breathing. This patient is drowning. So they haven't ingested fluid. They've had fluid shift into their alveoli. So it's the same thing almost. And they're drowning. So imagine their lungs and their brain's like, holy shit, my lungs are full of fluid. Let's increase our work of breathing. Let's recruit all those extra muscles that we need to use. And your patient is going to have extreme difficulty breathing. It's going to be noisy. So on auscultation, you'll have crackles or crepitations everywhere. So this is not like a pneumonia where it's on one side. This is diffuse drowning. And crackles occur from the air going through the fluid and popping, and that's why you get a crackle noise. We have edema. So this is more of what's occurred before APO. So we have that fluid overload, long-standing hypertension. So therefore we have fluid shift in our legs. So what you'll see in your patient overall will be edema. So mainly in the legs. It'll be pinning edema. Cool periphery. So what's cool periphery signify to us? It means that his left ventricle isn't pumping as much anymore. It's just flapping. And you have decreased cardiac output. So the left ventricle determines our blood pressure, doesn't it? So therefore we have decreased cardiac output. These tissues aren't getting the blood they need, and therefore they become cool because they haven't got a warm blood anymore. Fatigue. So fatigue just illustrates that this patient hasn't got that cardiac function. So their brain's starving of oxygen, starving of nutrients, starving of blood, and when we become fatigued and weak, our heart just can't keep up with daily life. Chest pain. Chest pain's a common finding because most of the time these patients will either have an arrhythmia or a heart attack that triggers heart failure to go into APO. So chest pain just sort of signifies that you might see that this patient might have had a heart attack or ACS that's triggered. Fast heart rate, that's just a compensatory mechanism. Hypertension, because that left ventricle is shit now. It's fucked. It's just flapping. It's not a good strong beat anymore. It's just flapping. And hypoxia. Like, there is no oxygen diffusion here. That blood is not getting its oxygen it needs. They're going to be hypoxic, and that hypoxia is going to be very resistant. So oxygen, supplemental, so non-rebreather or IPPV will not do much for this patient. It will help, but you're not going to see those effects that you see in other patients because you still have fluid in these lungs. So for this one, we just want to concentrate on this area. So APO or cardiogenic shock. So APO over time will go into cardiogenic shock, but that time is relative. It depends on what your patient is like. A 90-year-old male, a 60-year-old male. It all depends. So this patient can go from having normal heart failure, long-standing chronic heart failure, have a heart attack and go straight to cardiogenic shock, skip APO, or they could have APO over time, so like 30 minutes to an hour can go into cardiogenic shock. And then what happens after that is death. So what happens with cardiogenic shock? How do you know if your patient is in APO or cardiogenic shock? Tachycardia. So we're looking at a heart rate above 100 in an adult. Hypertension, so less than 90. If your patient is tachycardic and blood pressure less than 90, they're in shock now. With or without APO, as we said, it's a time continuum. They may skip APO and go straight to cardiogenic shock because of that heart attack was just so severe and it just screwed that left ventricle and you're going straight to cardiogenic shock, or they have APO because there's a bit more time. Treatment for cardiogenic shock. So they need oxygen, same as APO. Fluids though, they need fluids isn't indicated APO. Fluids here, more a conservative approach. They are in shock, so I believe fluids algorithm is 20 mils per kilo, but correct me if I'm wrong. But conservative fluid approach. Adrenaline, so if these patients are very hemodynamically unstable and adrenaline infusion is indicated in New South Wales ambulance. Urgent transport, don't mess around on scene with these patients. This is a load and go. They need urgent care, they need hospital grade care, they don't need HEMS, they don't need ICP, they need a hospital intensive care unit. No GTN or furosemide for these patients. So treatment for APO. So I want to break the treatment into for the lungs and for the heart. So that's essentially what we're doing here. So let's talk about for the lungs. So we have IPPV, so when you're back valve master patient, or we have CPAP. So CPAP can be improvised. So essentially what we want to do for these patients is we want to squeeze the bag as they're exhaling. So this is what's happening in APO. So we have fluid, the door opening, the Hulk is open, the door, adult can't close it, and door is open, fluid goes into alveoli, and they're filling up. However, if we put CPAP or IPPV into these patients, we increase the air pressure into the airway. So think of a puddle, and you have a normal air pressure around it, but then you blow onto the puddle, it'll disperse. So that's essentially what we're doing here. We're putting increased air pressure in the airways. So we're blowing in, so I can see the little lines here, they indicate you're squeezing off the BVM. And that, I can't really see it well, but the fluid is dispersed. So it's that puddle effect that we blow into. What this does though, it counters the pressure. So it helps. So that Hulk was pushing that door open and the adult couldn't keep it closed. But what we've done, we're a teammate. So we've come and helped that adult. So we're like Iron Man or something. And we're countering that door. So we've closed the door now. So the X's indicate the door is closed. We've countered the pressure imbalance. So we've closed that door now. And we split the alveoli open. So that's what it's doing. So not necessarily puts the fluid back into the pulmonary system, but it stops fluid shifting in temporarily. And what they need is for the heart stuff. So now for the heart. So we have GTN and diuretics, so furosemide. The goal is decrease the blood returning to the heart, therefore backflow, and make life easier for the heart. So let's look at how do we decrease blood returning to the heart. So we knew that the left ventricle couldn't pump out as much blood because it's fatigued, it's weak, and it's had like a heart attack, ACS, arrhythmias. What if we decrease the amount of blood going into the left ventricle? Therefore, it still pumps out a bit, but there's not as much backflow. So we have a person that you can't see because it's off frame. Person, blood goes to the heart, to the lungs, to the heart, to the body. So this is where we want to, this area here is where we make our impact for the heart. So we decrease blood pressure, we decrease blood volume. Blood pressure, we give GTN. Decrease in blood pressure will decrease the amount of blood returning to the heart. So as we decrease preload. And we decrease blood volume, so we do a diuretic. So they piss, urinate, and that decreases the blood volume, so we lose water when we urinate. Therefore, the lungs get less blood going to them. The heart gets less blood going to it. Therefore, there's less backflow here, and therefore we reduce the amount of blood that goes into this system. Therefore, we try and stop the alveoli becoming flooded. So we try and take away that Hulk. We take away the muscle of the Hulk being the backflow, and we try and take away his muscle, make him weak. Then for the heart, so we decrease resistance. So when we talk about resistance, GTN decreases afterload. So therefore, there's the aorta and the rest of the artery system. We've taken that small hose and we've made it bigger. We've vasodilated. So therefore, the left ventricle doesn't have to pump against as much resistance and can maybe increase the amount of blood that gets released from the left ventricle. And GTN is a vasodilator of the coronary artery system. So therefore, there's increased blood supply to that muscle. So that muscle here gets more nutrients. And that's how we treat APO.